Good afternoon and welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thank you for joining me for this broadcast on May 5th, 2022. Today's broadcast, let me outline it for you. We're going to be talking to some behind the scenes folks that make the scenes happen. So we're going to talk pre-testing with some of our nursing staff. And after we get done with that, then I will give a brief update in terms of COVID and what's going on and anything you need to know about that from our perspective here at the hospital. But without further ado, I'm going to bring on our team of pre-testing testers to talk with me. So welcome, ladies. So I will give you just a chance just to say who you are and what you do, and then we'll kind of go into a little bit more about, and when you do that, if you would, just kind of for the folks who are listening, give them a little bit more about like what part, describe your piece of the pre-procedure process. So we're going to talk things that happen before the actual procedures occur. So I don't know, Lisa, you want to kick it off?
So I do antenatal testing, which is a test that we're checking to make sure that the placenta is still functioning well in any pregnancy that may have complications or potential, like a mom that's worried or something about decreased fetal movement. So we encourage our moms that the doctor calls over to schedule the test, and we have them stop in admitting to come up to the floor. A lot of their education takes place once they get here. We ask them to eat and drink before they come, and that helps the babies move better. And then we do an ultrasound and monitor them to make sure that that placenta is functioning well.
Okay.
We happen to think we have the funnest test in the hospital because they get to keep their clothes on and they don't have a prep before. So,
Absolutely.
But,
and by the way, I've known Lisa for a long time. And before Lisa did this prenatal testing, she's been working on the OB floor for quite a while, and has been part of the deliveries of many a baby in the communities that we serve.
Yes, I still do that. I do that usually 1 day a week or 3 days a week, depending on my schedule.
So kind of keep your feet
get out of that.
Yeah, I'm guessing that the people that are watching this show, some of them recognize your face from when they were delivering or they had a family member delivering, and so
I'm in like second and third generations. So yeah.
Okay, there you go. Oh, what do you think, Lynell? You ready to give us a little spiel here before we go into more in-depth questions?
Sure. So my portion of the pre-procedure process typically starts about a week prior to surgical procedures that are scheduled. I work closely with the anesthesia department along with the surgeon's office to make sure that any preoperative testing has come back normal, that there's no abnormalities, and to ensure that the patient is as safe as possible to undergo a surgical procedure as possible.
Very good. And so, so those of you who are, Lynell is the person, when you show up to the OR, Lynell's been involved with making sure we've done everything we can to make sure that's a good experience. So that's Lynell. And Lynell, I'm just curious, what's the CAPA stand for? The initials behind the RN?
So CAPA stands for Certified Ambulatory Perioperative Nurse.
Okay.
So I'm certified in perioperative nursing function.
Okay. Great. Thank you. That helped, just for folks to know that it's not, you've done some training beyond your training to be able to do this role. And I should also ask you, Lisa, the RNC, what's the C?
I'm certified in maternal and newborn care and in limited third trimester ultrasound.
Very good. Okay. Kim, best for last here, right? Tell us a little bit about what you do at the hospital in terms of testing.
Well, I actually work on the clinic side. I work in the Digestive Health Services side on the clinic. So I actually do all with the other nurses in the office, getting patients scheduled for the endoscopies and the colonoscopies. So we do the teaching, educating for the prep of the colonoscopies, explaining to you how you'll prep for the procedures, getting ready for the admission, what you'll expect during your procedures, recovery for the procedures, all that fun.
Sounds good. And we'll get a little more detail about that in a minute here, Kim. But yeah, great. You know, I forgot to mention this. So for the three of you, I just want to wish you the day before it starts, happy Nurses Week. And so thank you. And and there we go.
Thank you.
Yeah. So we start Nurses Week celebration tomorrow. And I was talking to someone today and I didn't realize this. Do you know why May 6th is the day that we start celebrating Nurses Week every year? I didn't know this. I was talking to our chief nursing officer with Christy, and she was saying that it's Florence Nightingale's birthday. Yeah, I was like, that's pretty cool. That's a great idea. Now, granted, it falls on a weird day in that it's Friday that it starts instead of like a Monday and everything. But yeah, that's pretty cool. So shout out to the three of you as well as all our nurses here at the hospital. Okay, I want to go back to you, Lynell, and I want to talk a little bit more about the OR and surgery. So that's the world that you're living in. So it can be a pretty anxious time for patients to have a surgery. Just talk a little bit more what you guys are doing on the front end to help to do all that we can to help make patients feel less anxious when they show up for their surgery.
Absolutely. Surgery is definitely something that causes patients anxiety, whether it be their first time in the OR or multiple times in the OR. So part of my preoperative assessment is kind of getting a feel for them as far as if they are anxious. A lot of times I'll encourage patients to ask questions, voice their concerns. Sometimes depending on the nature of what we're talking about, I'll ask them, what has worked for you beforehand in the past, if you've had a lot of anxiety preoperatively. Mm-hmm. And then there's other things that we can do when they get here the day of the surgery to kind of help alleviate any nerves as well. The staff up here in our ambulatory surgery unit and the surgery department is very understanding that patients are understandably nervous about surgery. So sure. Taking time with patients, letting them kind of voice their anxiety or their concerns about things, I think really does help the patient.
Yeah, I agree. We had Dr. Chaplin on a few weeks ago. He's our anesthesiologist and our director of anesthesia department. And one of the words that he uses a lot is optimized, making sure patients are optimized prior to going to surgery. Lynell, can you give a little bit more about what you do, what we do to try to make sure that patients are optimized before they show up on the day of surgery?
Sure. So optimizing a patient for surgery is basically ensuring that a patient's overall health status, their comorbidities, so like their chronic medical conditions, are as stable as possible to decrease any perioperative complications. That's complications that can occur before, during, or after surgery. Patients with specific risk factors are typically sent to their primary care office preoperatively before they come to the OR. And if they're established with certain specialties, a lot of times they'll be referred to those specialists as well, especially if it's a higher risk procedure. Those providers may order specific testing, specific lab work, an EKG, other imaging to help provide information as far as if that patient's chronic medical problems are indeed as stable as they can be. If those providers, those specialists, feel as though additional testing is required, that would be scheduled ahead of time prior to coming to the operating room. If there's a patient that I talk to who has multiple comorbidities, is having a high-risk surgery, or some other issues that have arose during my interview with them, I'll forward that information over to our anesthesiologist, Dr. Chaplin. He will additionally look over that chart and then help in the decision-making process, whether that patient is truly safe and ready and able to undergo whatever type of anesthesia is required for that type of procedure.
Yeah, that makes sense. As you were talking, I was wondering, do you call all the patients, or some of it? Talk a little bit about that, if you would, Lynell.
So any patient that is going to be having anesthesia outside of OB, I will call those patients roughly about a week ahead of time.
Okay.
And complete a comprehensive medical, surgical, social, and anesthesia history with them, and collect other health information from them as well. And those patients, like I said, are typically called about a week ahead of time. So I would say I probably talked about 85 patients a week on average.
Okay. So a good chunk of the patients that are having surgery done at CGH, you're going to be talking to Lynell. Yeah, good. And that's just for folks to understand that it's a big deal to have someone looking over your information, your medical history, your chart before you come in for a surgery, because there truly are things that can be done on the front end to optimize your physical condition, to make sure, or to at least make it much more likely that you're going to have a good experience, the surgery is going to go well, and post-operatively you'll do well. So once again, why I wanted to have Lynell on here is just that there's a lot that's happening to make sure that folks have a good experience with their surgery. So Lynell, thank you for that. And I know that's not it is not a little responsibility to be involved in taking care of patients in this way. So, okay. And I've got to ask you this too, because it comes up still. We're still in this COVID situation. I got to ask it, what's the status of our pre-op COVID testing requirements, Lynell?
Currently, our pre-op COVID testing guidelines are, if it's a planned or possibly elective procedure, that those patients are all preoperatively COVID tested 72 hours prior to their procedure. However, there is a little variation in that. If a patient has had a positive confirmed PCR test within the last 90 days, they do not need to be preoperatively tested again prior to surgery. If you're at the 91-day mark, they're going to require you to have a pre-op COVID test 72 hours ahead of time.
Okay.
Another exception would be if it's an urgent or emergent case, and then we have a protocol for that as well.
Sure. Yeah, I just wanted to get that out there, because obviously we are looking to we're following the CDC in terms of they have like on the healthcare side of things, whether we're in a low, moderate, or high kind of area right with COVID. And so right now I'm told that we're more in that moderate range. And as a result of that, that's why we're still doing the 72-hour testing. We've had conversations about, do we need to do that? I think when we get down to the low level that we probably won't. But for now, that's why we're still doing it. So I wanted folks to hear that from Lynell. So thanks, Lynell. I really appreciate it. Thank you for hanging out with me. And I'm going to have you stay on the line just in case something pops up here, okay?
Sure, thank you.
So I'm going to talk, let's see, I think, who do I have next? I have Kim next on the line to talk to here on this. So Kim does a lot of work with people who are going to have, You're a grade school teacher, Kim. Donna. All right. Well, thanks, Donna. Thanks for the shout out. Was she a good student, Donna? We got to hear about that or not. Did she get? I doubt Kim got a bunch of detentions. I just can't see it. But maybe I'm not reading you right. All right. So Kim's doing the behind the scenes work for people who are having colonoscopies and upper endoscopies and GI procedures. So once again, GI procedures can be, for a lot of patients, that can be pretty stressful. Even the bowel prep itself can be pretty stressful for them. So in some ways, actually, the best. Okay, there you go, Kim. How about that for a ringing endorsement? So I wanted to talk a little bit about the bowel prep, because that has changed for people who haven't had a scope before or haven't had one for quite a while. Can you talk a little bit about what we're doing differently now with bowel preps and how that's been tolerated? It seems to be better by patients.
Yeah, so fortunately, now we're doing the Miralax bowel prep. So that consists of doing, in most cases, 64 ounces of like Gatorade, Propel, mixed with Miralax. So we prefer to use Gatorade or Propel. You can use a non-carbonated beverage if you don't like the Gatorade or the Miralax, or the Gatorade or Propel. Miralax is a non-tasteless powder that we use with the Gatorade. Gatorade we like to use because of the electrolyte replacement. The Miralax is non-tasteless, like I said, and we do like the Gatorade now because you can choose the flavor that you like. Miralax has less side effects. We're noticing that it's not causing as many abdominal cramping and nausea and vomiting issues. So the patients are tolerating it a lot better than with other bowel preps that were used in the past.
Yeah, I think it was it mag citrate? Was that that's the big jug of stuff that you had to drink?
Yeah, lightly, peg lightly, those bowel preps were used in the past, and those caused a lot more issues.
Yeah. For a patient who's done both, I wanted to ask the question because for a patient who's done both, big difference with the Miralax, because first of all, Gatorade is not the best, but it's a lot better than that mag, and you don't have to drink as much. So I at least found that to be a pretty much better experience the day before than the old way of doing it. You know, you'd hear people talking about they were gagging and everything with the old way, and this way, I don't think that's going to happen that much at all.
Right.
Yeah.
We've had better results with this.
Yeah. I also just wanted to give you an opportunity, Kim, from your experience, what would be some like pre-procedure tips for people that are going to be having colonoscopy or upper endoscopy scope that would make their procedure day flow better for them? No pun intended, by the way.
Right. Well, definitely a lot of patients will think that they need to eat a lot the day before. Don't recommend that. Recommend, not purging the day before. No pun intended, but you got to remember that everything you put in, you got to take out. So also make sure that you're pushing lots of fluids on your prep day. The more fluids that you push, it's going to cause less nausea on your prep day. Also helps with the abdominal cramping. Just also know that if you smoke marijuana, that definitely affects your sedation the next day. So we don't want them smoking marijuana for at least 48 hours prior to the procedure. That definitely affects procedures. Also with them pushing lots of fluids, it also helps the following day on procedure day. It keeps them very hydrated and it helps with IV insertions.
Yeah.
So just doing those steps is all beneficial.
Yeah. That's good to know. Kim, I've had, in addition to you, I've had at least a couple other of our nurses who work on the hospital side of DHC kind of talk about the marijuana situation. I didn't realize that. So can you go in a little more detail if someone has smoked marijuana, what does that do in terms of their sedation?
It can very much affect the sedation. It makes it very hard for them to be able to sedate.
Okay.
So a lot of times we will then have to reschedule them, and they have to go to the OR because we're not able to sedate them in DHC.
Okay.
So
yeah, so you literally can show up that day, and if you've had some marijuana, we may for your safety not even do the procedure, or do it sometime later in the OR because we can. Okay.
safely in the OR. Right?
Yeah,
So,
and I get it from a patient standpoint. In some ways, it's a stressful time, and if marijuana is one of the things that you do to help you feel less stressed, you may want to do that. But I thought we wanted to get the word out that please don't, because it does. It's not a good fit for trying to have a scope to have consume marijuana in any way. So good. Well, great. Thanks, Kim. I appreciate that. That's good feedback. I'm gonna segue to Lisa. Lisa, you ready?
I think so.
Okay.
Fire away.
Mom and Dad are watching. Whose mom and dad are we talking here?
Mine.
Oh, okay.
That's dangerous territory.
Now, where are you from, Lisa?
I grew up in Erie.
Okay, so we got mom and dad watching from Erie.
Yeah.
All right.
Mhm.
Okay.
Making
Shout out
good
to
on the
Erie.
education
Shout out
I
to
did,
Erie.
but-
Okay. All right. All right. So first question for you, Lisa.
Mhm.
How does it get determined if a woman needs this prenatal testing where they come to the hospital and do this testing?
Well, there's many conditions that, if you just think about the blood flow of the placenta, so like if someone has high blood pressure, which can affect the flow of the placenta,
Okay.
diabetes, advanced maternal age, substance abuse, if babies are too large, babies are too small. We see all of these people, and generally once they start in testing, they come at least once a week or twice a week until they deliver.
Okay.
For people that have suffered a loss in a pregnancy, it's very reassuring. And even if they're having a complicated pregnancy, the testing is very reassuring to them. We do a lot of education while they're seeing us about how to have a healthy pregnancy, and helping to connect them with higher level of care, or maybe social work aspect. We try to help them put the pieces together, because it's all nurses. There's 4 of us that do it, and we try to help them and coordinate with the office as well, and our coworkers in the OB department. We try to help them put it all together to have the best outcome. So.
Yeah, and when I hear advanced maternal age nowadays, I think it's 35 plus, right?
Yes.
It doesn't sound that old, but for
patients that
OB,
I know
that is.
Born could be considered that.
Yeah. Right. So anyhow, okay, that makes sense.
Yeah.
So, and I was going to ask too about when in the pregnancy in general will you start to have women that come that you will begin testing, Lisa?
Usually, like the earliest that they can come to testing is the age of viability, about 24 weeks, but generally most of them are anywhere from 32 weeks to, if we also do it for post dates. So some don't start till they're like 40, 41 weeks.
So 32 plus is the majority of your folks.
The majority of our patients in our area, that's when.
Okay. So obviously for women who are not used to coming to the hospital as much, it can be, once again, a little bit like it's a bit of a maze to, to do all that. How do you try to make that as smooth as possible for those ladies?
We try to tell them where to come in and exactly which door to go to registration. Our volunteers downstairs are just a wonderful asset to all of our patients. They help guide them up there to us, and I think the volunteers maybe enjoy talking with our expectant mothers as much as the expectant mothers.
I bet,
So
Yeah.
they're great for us. But yeah, they help them up here, and then we educate them a little more about where to go once they get here.
Yeah. And when we talk about prenatal tests, Lisa, can you, what are the different tests that you're doing up there, just so people understand that?
So the test in particular that we do 99% of the time up here is called a biophysical profile.
Okay.
And there are 5 components that they're scored on. 4 of them are on ultrasound. One is a non-stress test where we hook them to the monitor. And
Okay.
I always tell the patients, it's kind of like when you go for a physical and they check your heartbeat and then they have you run in place and check your heartbeat again.
Yeah.
We want to see the baby's heart rate go up when the baby's moving around in there. And then on the ultrasound, we measure the amniotic fluid level, the muscle tone. We want to see some small muscle movements, and we look for fetal breathing movements, and put all that together. And it's hopefully their score is 10. If not, we have troubleshooting things that we do to try to see what we should do next. That's
Sure.
why they can't come till after they're in an age of viability, the pregnancy is,
Right.
because sometimes the option has to be to deliver the baby.
Yeah. So part of that, you're part of the decision making in terms of when is it time to deliver this baby.
Correct. I call the physicians or nurse midwife and talk with them about what I've seen, and we put it all together and decide where we go from there. Probably 95% of the time, it's that, okay, we're going to just watch this baby again the next time. And sometimes it's maybe we need to make a trip to labor and delivery or have more testing done.
Yeah. Good. Well, that sounds like it sounds like a by and large a fun job in that you get.
It's really fun.
Yeah, and obviously there are times when it's not so fun, and that must be really just devastating. But
you have the highest of the highs and the lowest of the lows.
Yeah,
so,
you said it well. So good. I'm out of my questions. Anything else any one of you would want to add as I've been talking and asking other questions that you want to make sure that we get out to educate and inform folks? Going once, going twice, going 3 times. Lisa, Lynell, Kim, thank you so much for taking the time to hang out and answer some questions. And thank you for the work you do. And thank you a day in advance for being a nurse, and happy Nurse Week. Okay, now you're just back to me. So I'm going to be pretty short about the COVID stuff. And I just want to say that it's obviously we're having a little bit of an uptick in terms of cases, across the country, which is driven by these different variants of the variants of the variants. And so, that's what we were expecting, and that's what's happening. I will say that in general, fortunately, we're not seeing like a lot of the other surges where we have this really big, and I would call this kind of like a mini surge right now, but nonetheless, we're definitely gone up the number of people that have had it lately. But fortunately, the number of people that are hospitalized and getting really sick or dying is not going up to the extent that it has in the past, which is very nice and very, very encouraging. Our hospital, like lately, has kind of run 1 to 3 patients in the hospital. You look at the Illinois numbers, and we got down as low as, I think, 400 something Illinoisans hospitalized with COVID. I think when I looked yesterday, it was in the 700s, somewhere in the 700s. So it definitely has gone up some, but not to the extent that we've had in other situations. For example, Omicron, when it was really hot and heavy, was around, I think the number of Illinoisans hospitalized was about 4,400. So definitely better than Donna. Okay, thanks, Donna. Appreciate the question. So if you're over the age of 65, I would get the second booster. If you're over the age of 50 and you have a high risk factor, I would get the booster now, the second booster, that is. Definitely. If you're below the age of 50 and you're otherwise healthy, What the CDC is saying is that you don't need a booster that second booster right now, and to wait for whenever the new and improved booster comes out. I'm assuming this fall, because I think it's really likely that what the companies that make the vaccines are in the process of doing is trying their best to re-engineer the vaccines to account for the variants that we're seeing lately. And granted, it's going to be a moving target. So somewhat like the flu, my guess is it's not going to be perfect, but the closer you can get to the virus that people are being exposed to, the more likely that vaccine is going to be effective. And we know even now, and I'm just repeating what I've said many a time, but I'm just going to say it again. It appears that people who have been vaccinated and boosted, and then of course get the second booster in particular, but vaccinated and boosted people, by and large, they may still get COVID, but the vast majority of them are not hospitalized. And if they are hospitalized, they tend not to get, very, very sick. So it continues to be a situation where it's the people that haven't fully vaccinated, they're the ones that are not just getting COVID, but ending up in the hospital with COVID. And, I don't want any of us to have to be in the hospital with something like COVID, something that we could just prevent. And you can get sick, but not get sick enough to be in the hospital. So a long answer to your good question, Don. I appreciate that. So I guess my take home as far as COVID goes is get fully vaccinated. If you are in a higher risk category, if you're like in a really enclosed area with a bunch of people, I think I'd throw in an N95 if you're at high risk. Otherwise, for everyone else, I think you go about and you live your life and you enjoy your life and and be thankful, more thankful for every day that those of us who feel healthy can be healthy. Okay, I've gone about 33 minutes, and I think we have a shout out we want to give, don't we, Matt? In addition to Nurses Week, I wanted to just highlight Rachel Dietz is one of our dermatology physician assistants, and Rachel does some teaching for St. Ambrose PA students, and she actually got the Preceptor of the Year award. So I just wanted to give a shout out to Rachel for that. That's pretty cool. So we do have students that come through CGH and spend time with our medical staff, and Dr. Kennedy, one of our general surgeons, I think it was this year or last year, received the award for Preceptor of the Year for medical students that come out of Rockford that spend time with us. So thanks to Rachel. Shout out to Rachel and others who take the time to teach others who are going to be the folks that are going to be the next generation of healthcare providers. So Matt, I forget if I have anything else. I don't think so, but I'm going to keep talking just to make sure you don't tell me that I have other things to put up there. I don't think I do. Everybody, thank you so much for taking the time to watch. We will be back in 2 weeks and having one of our Growing Healthy series speakers that we'll be interviewing. Until then, hope you have a great 2 weeks. Thank you for taking the time to listen in. And this is Dr. Bill Bird, CMO at CGH Medical Center, signing out. Thanks for watching Facebook Live.